pretty much, if we are going to suffer the consequences of having to go to trial for a deposition, your chart is what's going to be pretty much what's holding you together and for your actions. So let's start. Training outline today, so we're going to go over the newly revised SOG. We're going to go over some report writing basics. Later we'll get into the preparation for providing a testimony. And then we'll get to ambulance billing as well. Cool. So sections of the PCR that we're going to focus on right now. First one is going to be your patient information. This is going to be obtained on every PCR that we write. This is our basic patient demographics. We're getting the patient's name, age, sex, their date of birth. We're going to try and obtain their social security and their phone number. Sometimes that's not always possible, but we want to make every attempt to get that information from them. Billing information, this is going to be the patient's mailing address. So sometimes we get called out to these facilities where these people are temporarily staying. We want to try and get a mailing address where they're actually receiving mail. We're not putting that their home address is, Sabana Grande, Genesis, or wherever, right? That's not where they live, it's not where they get mail. People are there for an extended period of time, but we want a home address. Our call type and location. So this is going to be one of those things that prompts us in our image trend. It's going to light up red. It's going to tell us where we were called out to. Did we go to a nursing home? Is this a single family home, apartment complex? This information is important as well. So that's going to include what you were dispatched to and where. Our response time and mileage. Usually that's all stuff that's going to be auto-populated in our CAD if we're doing everything right through our MDT. Sometimes that doesn't happen and our CADs are down for whatever reason and our times don't get populated correctly. So you want to, as best as you can, accurately have your times and your mileage correct. Medical and surgical history. So, of course, this is important on every patient. This is going to help with continuation of care of that patient. We want to accurately document all the pertinent medical history they have, what they're taking medications for. This is going to help in the continuation of care. If this patient becomes a repeat patient, this is going to help later on when other providers are running that same person and they pull that patient as a repeat. They can look at their history and have a better idea of what may be going on. You're going to an altermentation call and you can look in their history from previous providers and see that they have a past medical history of dementia. It can give you an idea of okay, well, maybe their baseline mental status is already not fully to par. So, our patient condition. So our patient condition is going to be basically how we're going to transport our patient. We're going to move on to our narrative. So every PCR is going to get a narrative, whether it's a non-patient, especially for refusals. If there's an AR number generated for it, that is going to get a narrative to it. Simple as that. Patient vitals. Every call will get at least 2 sets of vitals minimum. If it's a non-patient, there are exceptions to that. If they don't want an assessment, or that person tells you, I don't want you to take my vitals, that's an exception that we're going to document. But other than that, every patient is going to get a minimum of 2 sets of vitals. Any procedures you perform are going to be correctly documented. Put them in your procedures tab. They should reflect, same thing, your narrative. It's important to document our procedures. If you don't document it, it didn't happen. EKG monitor. So for our EKG, if there's any 12 leads done, we need to document that. Downloading our vitals from the monitor is important as well. You got to make sure your vitals are uploaded. You want to double check, make sure your 12 lead, if it was done, that it actually uploaded correctly. Sometimes we download that from our Zoll monitor and it'll say EKG's there, but if you don't look at it, there's nothing attached to it. that's an issue that we run into there as well. Any medications administered. So this one's super important. You need to document anything you gave the patient, obviously, but we also want to know, which would be in your narrative, like why did you administer the medication, for what reason, and what are the outcomes of that medication. So I gave epinephrine for trouble breathing, suspected anaphylaxis. What was the patient's outcomes? The patient's breathing improved, urticaria improved, or something like that. Unit personnel. So this should be something, first thing in the morning, you assign the unit personnel to your in-image trend. But we do have situations like in Station 1 and 10 where people are moving units, so it's important to update that if that's the issue. So if people move around, you need to go back and update who's on your rig, what their level of licensure is, because they're going to be the ones attached to that call with you. And our signatures. Signatures are super important. It's required for Medicare compliance. Every attempt should be made to obtain a patient signature. If you leave the hospital, you're back at your rig and you go, oh, I forgot to get that patient signature, you should make an attempt to go back in and get that patient signature. We shouldn't be trying to forge any signatures or anything like that. If you're not able to get that signature, again, document clearly why. Was the patient impaired, or they're due to a distress level, they weren't able to sign your computer. But it needs to be clearly documented of why you didn't get a signature.
Hold on, Tim. For ILS and BLS rescues, guys, those, when we perform a 12 lead, what do we need associated with that 12 lead?
Interpretation.
Okay. Interpretation by who or what?
Either monitor or
Beautiful. Thank you.
Yeah, absolutely. We'll get into that a little more as well here. So this covers some of the information of our new revised SOG. MOS shall provide the most complete, accurate, and standardized electronic records of patient care possible, because accurate documentation of care and services provided is paramount. So it's important for continuity of care for this patient and who we're transferring them over to. This documents everything previously done for that patient. These charts can get pulled. And like I said earlier, this is mandatory to meet state requirements for reporting and documentation of EMS reports. So our EPCRs are a field bridge. They're generated for every incident that we're called out to on an EMS call. Like I said before, they'll all generate an AR number. If you have a walk-in into your station, you have to call dispatch and tell them to generate an AR number for this call, and whatever the chief complaint is going to be for that. And then, like I said, this is going to include patient transports, patient refusal to transport, and all non-patients. All get their own generated AR number. You can have multiple people attached to one AR number. They could be an MVC, 2 different vehicles. You're getting 2 non-patients. They're still going to be attached to one AR number. So your chart should be completed no later than 12 hours from completion of the call. Waiting any longer than that causes a delay in billing. It puts a delay on your MedCom, so now your MedCom still has to review all these charts. If there's corrections that need to be made, they need to get sent back to you. However long that takes, the corrections get made, sent back to MedCom. They review it again, make sure everything's okay before they can send it off. So waiting, say you wait a second day to submit all your charts. Well, this is causing a delay for them. So now they have to go through all of that their next morning. And again, it's causes that delay where they're sending it back to you for corrections to be made and waiting to send it back off. So we love our MedComs and we want to help make their jobs a little easier. If you're unable to complete your chart for whatever reason, the next possible MOS, the responsible MOS, was your partner, should make every attempt that they can to try and complete that call and complete that chart. There are unusual circumstances where you're not able to, and you should notify your captain and your MedCom as well. They can kind of figure that out and see what needs to be done to get that chart completed and submitted. And we always want to make sure, every time, I'm sure this is a super common area, everyone's saying they get charts back, hey, can you sign your chart? We want first initial, last name, level of licensure, and your NIN number should be on the end of every narrative. That is your seal of approval that you wrote that chart and you vouch for everything that you did in that assessment. So we want to be sure to review all our EPCRs for accuracy and completeness. It's super easy to just kind of hit that re-download CAD, and it may say 100%, but they're missing pieces of information. So we want to review every EPCR for completeness and accuracy. We want to make sure what we're putting in our narrative is matching what we're putting in our tabs as well. Making sure our hospital that we're choosing to go to that we're saying in our narrative is what was entered in our tabs for our transport tab. Any corrections made will get sent back to you. You need to respond to your MedCom. Some of these get sent out for QAs. So this tab here is super important. Requirements for obtaining and documenting information should not be prioritized over providing high quality patient care and when the patient's condition warrants it. At no time should we be behind our computers when there's patients who need to be treated. That is not our first priority. Our first priority is high quality patient care. We should be taking care of them to the fullest effect, not hiding behind our computers trying to finish our chart so we can get back to the house and relax. Put your computer to the side. It's good to have if you need to document, okay, a medication was given, I can document that real quick. But we should be focusing on our patient and trying to provide the best care that we can to them. And the chart will come second to that. We also have, on scene, we have our captains and other people who can help document those things for us. Right. So our charts are protected under HIPAA, the Privacy Act, where this contains private patient information. They have socials and addresses that people can steal this information. You just shouldn't be leaving your tough book around. The back of your gurney left unattended, left open, sitting out for other people to see. This is private information for these people. You shouldn't be taking pictures on your phones of things and storing them on your phone. So we're going to talk about specific documentation. Right now, we're still using a D-chart format, as everyone I'm sure is very familiar with. So we'll just go over real quick what should be in each of these sections of your D-chart. Your D is going to be your dispatch information. This should include who was dispatched, for what reason you were dispatched, and when you were dispatched. And you can also include your NPDS code. Right? So just because we're going out of Station 1 doesn't mean Ladder 1 and Rescue 1 are going together, as we all know. So it's important to put who was on that call. Engine 2, Rescue 10. Dispatched to whatever came out as that call, trouble breathing, female trouble breathing, what date you were dispatched to, and then the coding on it to your NPDS. It was a 6 delta. Our chief complaint. The chief complaint is not always going to match the dispatch information, right? It can come out as trouble breathing when you get there and your patient has a completely different chief complaint. Dispatch is only able to get the information they can, and they don't see what we see on call or hear what the patients are telling us directly. So it may or may not be the same as your dispatch information. Your history. This is going to be subjective information that you personally heard. So this is going to be what information you obtained from the patient themselves or bystanders, things that they're telling you. Your history is going to be what led up to that call and why 911 was activated. What events were happening prior that somebody called 911 and why you were called out there. You may also include pertinent medical history in this section. There's a lot of times where people will put C medical history tab. I'm like, well, that's not very helpful. Like, you need to be putting pertinent medical history. Patient has trouble breathing. Well, maybe they have a history of PEs. That's pertinent medical history. They have a history of heart failure. Pertinent medical history. Allergies. again, they can go into this tab as long as they're pertinent information that relates to this. So if they're having trouble breathing, they're allergic to bananas, something like that to that effect, where it has a reason to be in your narrative. Your assessment tab, or part of your D chart here, this is going to be objective information. So these are things that you physically assessed. I palpated this patient's abdomen and they had pain upon palpation. In this, you're going to have your basically the questions that you asked this patient that elicited responses. What they tell you in response to those assessment questions is all going to go in here. You're going to want pertinent positives and pertinent negatives in this section here. Having pertinent positives and negatives lets the reader of your chart know that you were thinking on a deeper level. You weren't just a robot doing things to do things, but that you were doing these things for a reason, right? So I palpated the patient's right lower quadrant. They had rebound tenderness upon palpation. That can tell you there's some sort of inflammation or infection going on, or it could be appendicitis, but you're thinking farther than, oh, I just felt their stomach and it hurt, right? So objective information. Your treatment, this is going to be the care you provided for that patient. This is going to be what you gave or what you did for that patient, and you want to include why, right? Why did I give this patient fentanyl? I gave them fentanyl for pain. Why did I give them Zofran, right? These are all super simple things. You don't need to be putting the exact amounts you gave them in your narrative, because there could be discrepancies from your tab to your narrative, but I gave fentanyl for this patient's pain. Simple as that. Patient had left femur fracture, gave fentanyl for pain. You also can include in this section of why treatments were withheld, right? So, and you needed to establish an IV for this patient, and they refused. So, or you were unable to establish an IV. You know, they're a hard stick. You tried 3-4 times, but putting IVs were attempted and unsuccessful for whatever reason. Transport tab. This is going to include where you were transported to. Were you transporting code 1 or code 3? And in what position did you transport that patient? Those 3 things are very important. We always need to know if we went code 1 or code 3. Severity of the call and the nature. And where are they going? This is an important tab to review as well. A lot of the times, your destination can change in route. Your patient says they want to go to Rust. The captain's there charting stuff for you. They put in Rust. You're en route, and they say, well, actually, I want to go to SRMC. So in your chart, you put SRMC, but your patient disposition or transportation was to Rust. And so that chart's going to get sent back to you, and you're going to have to make the correction. Which all that can be fixed with just reviewing your chart, making sure that your narrative matches what you're putting in your tabs. In your transport can include what changes, were there any changes to the patient's condition while you were en route? Did they become more lethargic? Did they start to feel better after you gave them Zofran? Did their breathing improve after you gave them a Duo-Neb? That can be included in your transport, any changes that happened en route. And you're going to include in your transport as well who patient turnover was given to, and you want to include their level of licensure. It's important because we're not turning patient care over to the janitor, the custodian, or to a registration person, right? We're turning over to someone who is of equal licensure or higher. And that we also included in your signatures, right? Patient was turned over to a nurse or was turned over to a physician. But equal level of licensure or higher, and we're documenting that in our transport tab here. Your exceptions are going to include any exceptions to why something was or wasn't completed. It can be as simple as I wasn't able to get a phone number. Patient doesn't have a phone, that's fine. But document why it's not completed in your PCR. And again, always at the end of our charts, we're signing in. So first initial, last name, your level of licensure, and your MAN number. That's validating that you wrote this chart and you're accounting for everything that's in there. You are the responsible party for this call. So some specific documentation. So the MOS shall select and record the most appropriate primary impression. So our primary impressions, kind of wild. There's some that are applicable and others that are just kind of crazy. But you want to choose the one that is most reasonable for that patient and what they're presenting with, and what your suspicion is of what's going on. So this could be something where they're having trouble breathing, but your impression is that they have a history of anxiety. They said this feels like an anxiety attack. So your impression would be maybe the patient's having some sort of behavioral issue, or they're experiencing anxiety. And of course, that's after ruling out other tests, right? We're checking vitals and listening to lung sounds, other things like that to rule out other causes that could be causing this person's shortness of breath. Anytime a provider places a 3-lead or 12-lead on, it's going to be accompanied with the paramedic's interpretation, as Kevin Ray was saying. So if you're the paramedic on that call, you're going to be writing what you interpreted that 12-lead as. If there is no paramedic on scene, you will document the monitor's interpretation. This is important too. I mean, you could be basic bus, there's nobody available, and this monitor is saying STEMI. So there are things you can still do. You're going to document what the monitor told you, and even if you're a basic or an ILS bus, you can still activate STEMI alerts. You tell that hospital, my monitor is interpreting this 12-lead as a STEMI. You can activate the STEMI alert. There's no problem with that. They can always cancel it at the hospital, but it's better to err on the side of caution for that patient and be ahead of it than, patients presenting with chest pain, you get there and you haven't done a 12-lead, or you haven't done any of those things to activate the STEMI alert for their care further on. Demographic information, again, make an effort to obtain it. Sometimes you can't, but you want to make every effort to get their demographic information, like we said, name, age, date of birth, sex, social security number, and a phone number, and their correct mailing address. Signatures. So the MOS completing the report shall be responsible for obtaining the following signatures. So we're going to need a parent or a parent guardian or the POA. So always be trying to get a patient signature if we can. If we can't, we'd like to get some sort of like patient representative, whether this is their POA or if it's a minor, you're trying to get their parent signature. But somebody who is going to be representing that patient. Like I said, whether themselves or someone else, like a family member. We're getting our transfer of care signatures from our nurses or our docs. This is with every call, as you all know. If you're unable to get that signature, you need to clearly document why. We needed to transfer care over to somebody. Like I said before, it needs to be of equal licensure level or higher. Controlled substance waste signatures. Anytime we break that narcs box open and we're giving any narcotic or benzo, a controlled substance waste signature needs to be obtained. If your patient is unable to sign due to any reason, altered level of consciousness, they're impaired, they've got 2 broken arms for whatever the reason, you need to put why they were unable to. There is a drop-down box. It will say, altered mentation, they're unconscious, impairment of extremities. This is something that we're going to document of why we weren't able to get the signature. So when we're getting these signatures, it's important to explain to them what they're signing for. What they're going to be signing for is HIPAA consent. So this is saying all your information is going to stay private. We're only using this information for billing purposes and to provide care for them at the hospital. They're signing for consent for billing. They're saying, yes, I allowed you to treat me and take me to the hospital. I know this is going to accrue a bill for me, whether it's paid by them or their insurance, but they're consenting for this treatment. If it's a refusal of transport or a non-patient, they're signing, indicating that they understand what they're signing. If they're in police custody and you need to get signature from them, but you can't, they're, for whatever reason, hysterical, combative, aggressive with you, and you're like, I'm not getting a signature from them. It's a danger to you. An attempt should be made to obtain a signature from the police officer. So you're explaining to them the same things. You're telling them your concerns for that patient. If you feel like they need to be transported, you would make an effort to get that patient transported. But you would need to get, if they're saying they want a refusal, that patient's not going to go, they're under arrest for whatever reason, you can ask that police officer to sign as a representative for that patient, and including in your chart the risks involved. You're going to explain to that officer the risks involved of the refusal. If a patient or a person other than the patient signs the report, you need to put that in there, who that patient was. Was it an aunt, an uncle, a school teacher? Someone who is responsible for that party needs to be documented who that person is. Was it a grandparent, right? Who may be babysitting for the mom, but it needs to be documented who that responsible party is. Refusals and non-patient reports. So there's a big difference between refusals and non-patient reports. So treated and released, this is going to be someone who has a medical complaint of illness or injury and requested an assessment from you. You went out there, you assessed them, you took vitals, and you did something for that patient, and they decided, no, I do not want to go to the hospital. So you're going to need your 2 sets of vitals on every refusal. You're going to document accurately the complaint of their illness or injury, and you're documenting. You're going to document basically why they refused the assessment. And then a non-patient, this is someone who had no signs of illness. They had no complaint to you. It was a motor vehicle accident. They said, I'm fine, I don't want an assessment, I'm not hurt, don't want you to check my vitals. You can get non-patients on patients like that. This one's not going to require you to get a set of vitals. You do have to do a brief narrative of what you were called out to. If it was an accident, you can describe the scene of an accident. But this non-patient is not going to require you to get vitals. You still do need your signatures, and that they're understanding that they don't want an assessment and they don't want to be treated. So they're going to be signing for that as well. So in all refusal and denial situations, we need to make sure that this patient has an ability to make decisions for themselves. They have to have what we call like a decisional capacity, decisional making capacity, and that means they have to understand that a decision has to be made. They're not confused about what's going on, or they're not sure, but they're understanding that they're either going to go to the hospital or they're choosing to stay home. They're understanding the risks of that decision. You're explaining to them, we're leaving you here, the risks of choosing to stay could include up to your possible death. That is the most extreme case, and it's letting them know that. And they have to be able to communicate those risks back to you. If they can tell you, yes, I understand that I could die if I stay home. That is a decisional making capacity. So, and these are things that we're going to document, right? We're going to document their level of consciousness. Are they alert and oriented? And do they understand actually what's going on? Do they know why you're there? Any other information? This is just your refusal criteria, right? Are they under the influence of any drugs, any alcohol, and can they make those decisions for themselves? They have to be over 18 years old to make that decision for themselves, considered an adult, or they have to be an emancipated minor, military. They have to have no signs of suicidal tendencies or homicidal tendencies. They cannot be a danger to themselves or a danger to others. If they're for whatever reason driving crazy on the road, they become a danger to somebody else. And then vitals have to be within normal limits. Not always the case, but it should be along with their like established baseline. If they already have a history of hypertension and their blood pressure is like 137 or whatever, that could be normal for that patient. Like, yeah, I live in that range. Great, okay, that's good. They don't have any other associated symptoms with that. They don't have chest pain, and that's normal for that patient. And their neurological assessment, if they have history of stroke and they have deficits, these are not new deficits, that's something that should be documented as well, that is a normal baseline for that patient. They have whatever deficits, that is normal for them. You should document your concerns for patients refusing transport, and you should explain that to the patient. Clearly explain to them, I think you may have this going on, or for whatever reason, I think it's best if you get evaluated at a hospital. I like to tell people, I think if it's important enough where you called 911 and it was important to you, it's important to us, and we think you should get evaluated by a physician. There's only so many things we can do in the field and see. They need further care and care that we cannot provide in the field. If for any reason you're concerned or there's a bizarre situation and details are unclear and you just don't feel comfortable about leaving that patient there, you can always call MSEP. You call through the AAS dispatch line, they can connect you with an EMS consortium doc and explain the situation to them. Say, call on, hey, Fire Medic Aguilar, Rancho Fire, I'm here looking for advice. I have a so-and-so patient who is altered, or you can say they're under the influence, but they're answering all my questions appropriately. So if for any reason you feel uncomfortable getting a refusal, you can kind of help spread a little bit of that liability and ask the doc for some advice. And they can tell you, yeah, well, they're at home and they're intoxicated. If they have a family member there who can stay with them and watch them, you can feel comfortable with you getting a refusal. Great. Get that doctor's name and document it. Against medical advice, it's only documented when an on-scene provider contacts MSEP. And here, MSEP's name shall be documented in the narrative. That's important to know, right? We want to know who gave you those orders because it's coming from a higher level of licensure. Takes a little bit of that responsibility off of you. Not completely. This is still your call, but you're at least documenting that the liability was spread. This doc was aware of the situation, and they told you they felt comfortable with you getting a refusal. Right. So minors are not allowed to make treatment and transport decisions for themselves. Right, less than 18, you need to contact a family member or guardian. Minors who are either illegally emancipated, if they're married, or serving in the military. There's another caveat to that one where if they are under the age of 18 and pregnant, they are allowed to make decisions for their child, but not for themselves. It's really weird, but if they're under 18, their mom and dad are still making decisions for that female, but the mother can make decisions for her child. Okay? It is a weird caveat, but every effort should be made to obtain evidence of these situations and document it in the narrative. Like I've said before, of like who is representing this patient, and knowing your refusal criteria is super important. You should know where to go into Vector Solutions and be able to find it. We do have a chart in there that has all the refusal criteria. So if you're having incidents involving like many minor patients, it's a school bus that was sideswiped, you can create one chart and have a single form on there with a school representative. You can have all these non-patients attached to one chart. This can be, like it says here, a picture of the manifest with all occupants' names written or typed on a sheet. We can take a photo of that with our Tough Book, or you can document that, and you can do all the non-patients in image trend. In case where a minor or person under the supervision of POA refuses or denies illness and injury or treatment and transport, and the responsible person is not on scene, you need to make an effort to contact that person, getting verbal consent that they do not want their child transported. If you get called out to a school, mom's at work, and you're able to contact her, the school has mom's phone number on file, contact mom, let her know the situation. She may tell you, no, I do not want my child transported. You're getting verbal consent of refusal and documenting who she is, what her relationship is to that patient, confirming, like with the school if you're able to, that this is this patient's mother, and documenting that in your narrative. Paper forms mostly get used often in like motor vehicle accidents. If you have multiple patients, it makes it pretty easy to get information quickly. We don't want to be sitting out in traffic for super long, right? It's pretty high risk, dangerous areas. Risk of getting hit by other vehicles. So if we can get just basic demos real quick on paper forms, get the signatures that we need, and then we can document all the demographic information afterwards. So right here, large number of people, paper forms are able to be used to avoid spending excess time on scene. We also have this issue, if your MDT is down or your Tough Book is down, you're not able to log in information, you can get paper forms and get the information that you need from them. So our quality assurance program, there are certain calls that will get sent to QA for review. These are going to be things like your code 3 returns, any cardiac arrest. If we use any special skills on that call, they'll go to QA. If there's any consortium contacts on scene, goes to QA. Mass casualty incidents, and any critical care transports. Those all get QA for review. The purpose of that is checking for accuracy and compliance with patient care guidelines. So those are going to be submitted by your EMS lieutenant. They're going to review all those charts. Any issues or concerns, they're going to be sending that back to you. And it's going to be sent to you by your city email. So if you receive an email from your MedCom for any clarification or any information that's missing from your chart, they're going to send that to you before the end of your shift. If you do not respond to that, we need to start responding to our lieutenants in a timely manner, so they see that we are aware, we know something is wrong with our chart, and we're making an effort to correct it. If you do not respond to that first QA note, the second one will be your captain, your station captain will be CC'd on that. If you continue not to reply, if there's a third attempt to notify you of like, hey, this chart, there's something missing, you need to correct it, that can lead to further disciplinary actions now. These are time-sensitive documents. We need to send them off to billing so we can get paid for these calls. Anyone have any questions? Awesome. Get into some report writing basics.